Hello everyone, my name is Caitlin Murphy. I'm an RN to BSN student at Fort Hays State University. Thank you all for coming. I also work here at Latham Medical Center. I work in the progressive care unit and have worked there for about the past year. When you walked in, you should have grabbed a packet of papers. If you did not do that, please do that at this time before we get started. The first one is just some information about alcohol withdrawal, which is why we're here today. So you can read that one at your leisure, but the other two, please follow along when we get to the slides, and I'll tell you which ones to use. So how many of you guys have taken care of a patient withdrawing from alcohol? Have you found it hard? Has the situation been controlled? How confident did you feel? Did they have to go to ICU? Alcohol withdrawal can be kind of scary and intense. And here lately we've been having an issue with alcohol withdrawal patients just kind of being uncontrolled, whether it's due to nurses not really knowing how to measure, how to take care of them, or how to distribute the medications properly. There is a policy here at Latham Medical Center, if you did not know that, and we'll go over that today too. So, the main reason this education is happening is because we have had a lot of patients here lately that their symptoms have been uncontrolled and they've been having to go down to the ICU to be intubated and sedated. This can just arise with a lot more complications, so we try to prevent that, but we'll talk about that later. So, here's a couple previous questions for you. How comfortable are you when taking care of a patient who is actively withdrawing from alcohol from 0 to 10? Can you tell me how comfortable you are? Think about it. Do you get stressed out when you hear that you're going to have a patient with alcohol withdrawal? If you haven't ever had one, that can make this question a little more complicated, but if you haven't had one, then just think about, okay, so do I feel like I know anything about alcohol withdrawal? Do you know how to read the policy and follow it? The second pre-test question is, what is the preferred drug at a Latham Medical Center for treating alcohol withdrawal? Alright, do any of you guys know that one? And then, what do you monitor in telemetry when a patient is taking Haldol? So telemetry is our cardiac monitors. And then according to the alcohol withdrawal protocol, when do you contact the physician if the medications on the MAR are not working? So kind of keep these questions in your mind as we go through this PowerPoint. You should be able to answer them at the end, and we can talk about them then if we need to as well. So we have 3 objectives for today. The first objective is describe alcohol withdrawal, including signs and symptoms to watch for and treatment options. Second objective is you should be able to explain the current alcohol withdrawal protocol used at a Latham Medical Center. And the third objective is you should be able to identify medications used in alcohol withdrawal protocol and when it is appropriate to give them. So you should be able to do all these at the end of this class. And there will be plenty of time for discussion as well. So, most importantly, what is alcohol withdrawal? Alcohol withdrawal can occur as early as 6 hours after alcohol intake stops and can persist for up to 7 days. So alcohol use disorder affects up to 7.2% of the adult population and 800,000 teenagers between the ages of 12 and 17. That's quite a few people. It can be hard to diagnose if patients are not honest with staff about normal alcohol intake. You know that not everyone is honest about how much they drink. So this can make it a little more difficult to watch them, monitor for this, or to know if this is even going to be a problem or not. So approximately 8% of patients with alcohol use disorder will have some type of alcohol withdrawal. This is where it's important to know the symptoms. Symptoms can range from mild to severe. We'll cover those in the next slide. Early withdrawal can start anywhere between 24 to 72 hours. Patients can show symptoms earlier, but not often are they bad enough that the caregivers would notice unless looking for it. So if a patient has come in and has not been officially diagnosed with alcohol withdrawal to where you've initiated a protocol, you're having to watch for it, you might not even know that they're starting to withdraw. And this is where it can become a problem if we don't recognize it, because we don't know how much they drink, or even if they were honest and we just don't know what to look for, we may not be treating it adequately. This is where we can start having some more of those severe symptoms where they have to go into the ICU. So the Diagnostic and Statistical Manual for Mental Disorders states 2 main criteria for alcohol withdrawal. There must be clear evidence of cessation or reduction in heavy and prolonged alcohol use, and symptoms of withdrawal are not accounted for by a medical or another mental or behavioral disorder. Just kind of what we talked about already. Mortality rate is less than 1% with proper treatment. This is why it is so important that we treat alcohol withdrawal seriously. That needs to be treated like you would any other illness. You know, if somebody comes in for pneumonia, you're going to give them the steroids and the breathing treatments. You're not going to hold those off. And this is kind of the same thing. So before we move on, can any of you tell me what some symptoms of alcohol withdrawal are? Do you remember this from nursing school, or even if it's just a wild guess, can you throw it out there for me? Alright, so this is just a table. It kind of goes over some of the major signs and symptoms. So, alcohol is a central nervous system depressant. So when that is taken away from the body, it causes autonomic hyperactivity. Sounds like some big words, I know, but this is what leads to the symptoms that are witnessed. So normally, when you drink alcohol, your system is depressed. So, you know, it's kind of like a sedative. So you aren't going to have like fast reactions or any of that. So when it's taken abruptly away from the body, when your body gets used to it, it's like an amphetamine almost. It's going to get you hyped up. So if you look at your minor symptoms, you have anxiety, insomnia, GI upset, so this is your nausea, vomiting, diarrhea, headache, palpitations, anorexia. This is also where you can start to have a little bit of diastolic blood pressure problems, and their pulse can also start to get a little tacky. So we monitor all this, so kind of watch for some of these because they're going to do these before they move on to the rest of them. So they can also have hallucinations. Hallucinations can start as early as, 12 hours. Most commonly visual, but they can also be auditory or tactile. Usually you can ask the patient straight up if they are hearing or seeing things that aren't there. Most of the patients that I have had that have had alcohol withdrawal, they are very honest about this stuff because they don't understand what's going on. Because that doesn't mean that every patient will be. So some of this is visual. You're going to have to watch. Are they talking to somebody that's not there? Are they like reaching for stuff in the air that's not there? Hallucinations will usually resolve within 48 hours. It can cause seizures. The bad thing about alcoholic withdrawal seizures is that they may not show any other symptoms before that. They might just start having a seizure. And if they've had a seizure in the past, then they are more likely to have one when they are withdrawing. So it's very, very important to monitor for this. When they are admitted, you should be asking if they have ever been treated for alcohol withdrawal, if they admit to drinking, and then you need to ask if they have a seizure history, because this can be very important for medications and for just monitoring and making sure you have your seizure precautions and all of that on there. So last but not least, so these are kind of your moderate stages, the hallucinations and the seizures. So the severe is the delirium tremens. This is a medical emergency. This is very, very bad for the patient. So it can result in malignant arrhythmias. So this is your VFib, VTAC, all these cardiac arrhythmias you don't want. Severe electrolyte disturbances. So this is where you're going to monitor your electrolytes, your potassium, calcium, magnesium. All those can also affect your heart. Dehydration. That's another one that can, kill you, obviously. So some of the major, we call it DT, symptoms are the agitation. This is different than hallucinations. You can have a little bit of delirium and still be able to manage it, but hallucinations can be, or agitation can be more serious. This is where they can start trying to, hurt themselves or getting agitated with staff. So this is where patient safety can become an issue. They become disoriented. In your minor symptoms, they should be completely alert and oriented. They might not be able to remember one thing, but with DT, they're completely disoriented. This is going to be your patient that has no idea what's going on. They're agitated. They're trying to get out of bed. They're swinging at you. It's one of those patients you think you're going to have to get restraints on. Their vital signs will also go all out of whack. So this is where you get extreme tachycardia that doesn't go down or go away. You'll have like malignant hypertension, so it's like hypertensive crisis. It's going to be super high. They'll get a fever, and they'll start sweating like crazy. They're just going to see it. You're going to see it sweating profusely from all over their body. So if this is going to happen, it's going to peak at 5 days. So they might start showing symptoms of this before that, but it'll peak at 5 days, and it can last up to 7 days. This is where they're going to be downstairs on a ventilator with sedation, getting fluids and electrolytes and trying to keep them alive. This is where your severe complications can occur. So our goal is, even if we don't do prophylactic treatment, because our policy doesn't let us really start treating until they start showing symptoms, we do not want them to get to this level of withdrawal, because it can be really hard to get them back out of it. So how do we monitor alcohol withdrawal? Have any of you heard of the CWA scale? It is the Clinical Institute Withdrawal Assessment. This is like the advised or revised version, but it is the most widely used tool to assess severity of alcohol withdrawal. It does not predict alcohol withdrawal. So this scale is great for measuring your symptoms and how far someone is withdrawing, but it can only be used on someone who's already withdrawing. So this is back to, it's hard to give prophylactic treatment for alcohol withdrawal because we only treat it when it's actually occurring. So it assesses 10 different items, and there's specific scoring for each one. It is essential that assessments and reassessment are performed frequently. The treatment we give is dependent on our CWA scores. So it's very, very important that we do these right. We know how to do these, and we know how to act on them from here. So if you pull out your packet, you should see this CWA assessment in there. We're going to kind of go over this. If you have any questions, please ask me. Does this look familiar to anyone? Have you seen this? Have you used this on the floor? Have you never seen this? Have no idea what I'm talking about? Alright. Okay, so first, we're just going to kind of go down the line here. You can see at the top where you're going to take their pulse. You're going to conduct vital signs basically with every CWA assessment, okay, because this is part of the assessment. So you're going to take their pulse and their blood pressure. You're going to take their temperature. And those are really the big ones for this. So the first one is nausea, vomiting. Remember how we said with the minor symptoms, GI upset is common. So you're going to ask them, do you feel sick to your stomach? Have you been vomiting? Do you feel like you're going to vomit? If they say no, you can see it's a 0, mild if it's a 1, intermittent it's 4, and If they're actually vomiting, it's 7. So you can read those and see. So depending on what they say, that's their score for that question. So the second one is tremor. This is one where you have to ask them to actually extend their arms out in front of them, and you're going to watch and see, do they have a tremor? Do you see one? If not, place your hands underneath theirs as well, because sometimes you can feel it on their hand. You might not be able to see the tremor, it might not be that visible, but you can feel it if you put their hands to where it's just barely touching yours. So when you're doing that, also feel to see if they're sweating. If you look at the paroxysmal sweats, so you know there's obviously no sweat, there's beads of sweat, and there's drenching sweats. But unless you're actually touching the patient's hands, you're not going to know if their palms are moist. So whenever you're doing the tremor, it is very helpful to put your hand underneath theirs, and you can also feel if their palms feel moist, like their palms are sweaty. You'll ask about their anxiety level. Do you feel nervous? You know, are you familiar with anxiety? Do you feel like you're having any anxiety? So you'll grade them accordingly to that. Agitation, this is an observation. You know, are they acting normal? Do they seem like, you know, they're getting restless? You know, you can read that and kind of see what to do. There's tactile disturbances. So this is where you're like, if they feel pins and needles on their arms, any burning numbness, you know, do they feel bugs crawling on you? This is kind of like, this is part of your hallucinations. So this is not really visual, but it's, you know, you're hallucinating that you're feeling things on you. So this, you can see, has a lot more options. So you'll do which one is most appropriate for the patient at that time. Then you have the auditory and the visual disturbances. These are your hallucinations. Are you hearing things that aren't there? You know, do you feel frightened from things that you're hearing? And then there's the visual, you know, obviously this is, are you seeing something? Are the lights too bright? Is the color different? Then there's the headache. You'll ask them if their head feels heavy or if it feels any pressure. So then you'll rate kind of the severity for it. And then you assess their orientation. So this is where you're seeing, are they alert and oriented? Are they, you know, starting to become confused? Because this can mean that they are starting to get worse with their alcohol withdrawal. So for charting this, I did it on the slides, but it is in your iView. So you'll go to your iView. It is in your patient assessment part. And there is, it says ETOH OMC withdrawal. And so you'll click on that, and then you can, it's like the rest of our charting, you click on the box and put the appropriate answer. And it'll automatically total up the score for you depending on what you put, which is nice. So you're going to put in what their pulse is. There's ranges. It's like less than 90, 90 to 110, and then greater than 110. And it's like that for the diastolic blood pressure, and then it'll ask if they're running a fever. So you hit yes, no, put in the parameters for their vitals, and then that's where you're going to put, you know, are they hallucinating? Are they oriented? Are they sweating? Do they have any tremors? Do they have a past medical history of alcohol withdrawal seizures? You know, have they had any seizures? You're going to put all that in, and it's going to give you a number. So you won't have to actually calculate this yourself, but it's important that you know how to if you would need to. So when you put in alcohol withdrawal protocol, you have to have a doctor's order. Because as you can see from this, like there are medications and stuff that you can order if you need it. Like this is just showing your nausea medications if they're having nausea. Sometimes it's good to have it just in case. But then you'll also see that it automatically, for care monitoring, it initiates alcohol withdrawal protocol care monitoring. So this is where it's going to pull up and task you for your alcohol withdrawal score or your CWAL score. So make sure that you're documenting those every time you do it. They also have you document pulse checks. Alcohol withdrawal it can mess up your body in so many ways, and it can cause like clotting issues and everything. So it's important to check your pulses, make sure the blood is still perfusing. But this is how it'll look. You'll check mark what the doctor wants. Most of the time, these top parts, it's going to be, you know, everything, and then you can take off what you need. But the medications, you need to ask them which medications they're doing. They should be on the electrolyte protocol, so please make sure that that is clicked, because that's very important. Actual protocol, when you click on the little paper beside alcohol withdrawal, care monitoring, where that was at, this is what's going to pull up. This is our actual protocol. So as you can see there on the left, it talks about the labs. You have one-time orders, so make sure that those were done. A lot of time they're going to be done in the ER before they come up, but you might still go ahead and make sure that they have all those. You also have a couple one-time orders if you need it. Since these are in the protocol, you do not have to call a doctor for it. So you see the clonidine. So this is for the high heart rate and high diastolic blood pressure. And then when you're treating this, you're using benzodiazepines. So you also have something for benzo overdose if you would need it. This is something that you use, and then you notify the physician what is going on, so that way they can decide if they need to hold something or what the best course of action is. So then we go down, and you can see the headings there. One's for symptoms, and it goes mild, moderate, and severe. You have diazepam, lorazepam, and Haldol. It tells you how often to assess, what to use to treat them once their symptoms are controlled, and what to do if it remains uncontrolled. So this can be a pain to use when you're trying to conduct the seawall and find all this stuff in the MAR, because in the MAR it's not going to look like this. You know, you're going to have each medication with the dose, and it's going to, underneath it in tiny letters, it's going to say used for seawall score, blah blah blah. So know that you do have this for reference if you need it, okay? It is helpful. It can just be kind of hard to look at and understand sometimes. But if you have any questions, please ask. And don't be afraid to ask some of the older nurses or others who have experience. Your nursing supervisor is also a very, very good resource, so please use that one. So how often do you need to do a seawall assessment? You'll do one on admission. This is if they are actively being admitted for alcohol withdrawal. If this protocol has already been initiated, so we're monitoring for it, then this is what you're going to do. So you'll do a seawall upon admission. Make sure you explain to the patient what you're doing, why you're doing it. Sometimes they can get a little agitated. They might be in denial about the problem. They might not want to acknowledge that they drink, but do explain it. You'll do it hourly, twice, with vital signs, and then every 4 hours or per symptom triggered treatment guidelines. So if you go back to the protocol chart, it tells you how often to treat it depending on which severity of symptoms that they're using, which medications you're using. So for mild treatment, you recheck for 2 hours, you know, so you treat them, recheck for 2 hours. If their seawall score is stable or less, you know it's okay, then you don't have to do anything else until for another 2 hours at that 4-hour mark. If it's moderate treatment, you're going to recheck in 15 minutes. With those medications, you can give it every 15 minutes if you need to with some of them. And this is important. Don't be afraid to do that if you need to. They can progress very quickly from moderate treatment to severe symptoms, and we try to do everything we can to prevent that. So the good thing is if the patient is not actively withdrawing, you can decrease the checks to every 8 hours when the score is 5 or less for 3 consecutive checks. And then you can discontinue the alcohol withdrawal protocol after 3 consecutive 8-hour checks and the seawall score is 5 or less. This means that they're not withdrawing, they're not going to withdraw. So you don't have to keep monitoring them for this. So here's the 3 main medications for alcohol withdrawal. these are what are on the protocol. So we have 2 benzos. The first one is diazepam. This is your drug of choice for withdrawal. And it lowers the incidence of seizures and delirium. It also has a self-tapering effect with a long half-life. So it's going to stay in the system just a little bit longer, but it tapers itself. So it's not like they're getting a lot of medication and it's just abruptly going out of their system. It's going to slowly leave their system, and so it's going to work longer. The only thing with diazepam is if the patient is 65 years or older, the doses are cut in half. And you can see that in your alcohol protocol. It'll tell you to use only half. So the second benzo is lorazepam. This one is used primarily for patients with hepatic impairment. However, right now there is a shortage of diazepam, so we have been using lorazepam for every patient. There is no dosage warnings for lorazepam, so you don't have to worry about that. If you feel like your patient's getting drowsy, or you feel like they're getting too much medication, don't just stop giving it to them. Obviously you can hold it, but then talk to the physician. Maybe they want to do half a dose. Make sure you tell them the CWAL scores and that they're just getting drowsy, but they're still showing signs and symptoms. This way you can get it under control. So the third medication we use is Haldol. This is what you're going to use for delirium and agitation. So when the patient starts to get agitated, go to your Haldol. The only thing is this is where it's important to know if they have a history of seizures, because you don't want to give the Haldol to someone with seizures. It can actually increase their likelihood of having a seizure. This one is also important that they be on telemetry or cardiac monitoring. You need to watch their QTC. Haldol can cause your QTC to prolong, and then that can start to cause heart problems and heart arrhythmias. So it's very, very important to watch and monitor that. Okay, so because of our issue with the protocol just being kind of extensive and long and hard to understand, I've made this algorithm that will be presenting to the board here in another week or so, and it just kind of helps break down the medications, makes it a little bit easier to understand. So we'll kind of go through this. So the first at the top, it says the patient showing signs and symptoms of alcohol withdrawal. This can be, yes, they were admitted for alcohol withdrawal, so you conducted a CWAL already, and this is kind of what you're seeing. Or it can be like, I think they might be withdrawing, I'm not sure. So you'd go ahead and go to yes. So you'll conduct the CWAL. Is the CWAL scale greater than 5? If it's not, just continue to monitor. If you feel like they might still need something, you can always contact the doctor and just ask. You're not going to get in trouble for asking. So if it is greater, is the patient agitated or anxious? If they're not agitated or anxious, you technically do not have to treat them right now. This could just be like their vital signs, but it could be from, your vital signs can get kind of out of whack just from getting up and walking and your pulse goes up, and that'll affect your score. So keep that stuff in mind as well. So if they're not agitated or anxious, you do not have to treat them. You can just continue to monitor, do another CWAL. If they seem to get more agitated or, that 4-hour mark. So if they are agitated, is their score between 5 and 14? If it is, then this is where you're going to start giving your medication. So you'll go down to yes. You see give diazepam, 5 milligrams of lorazepam. And then you're going to assess. So remember, with your mild treatment, because this is your mild treatment, you will assess in 2 hours. So are they working? If they are, then you can continue the current treatment. Okay, so keep doing that diazepam, that lorazepam every 4 hours when you conduct your CWALs. If the medications do not seem to be working, then you're going to follow and go over to moderate treatment doses. Okay, this is important because you can give, if it's not higher doses, you can give it more frequently. And this is where if they're starting to get agitated, your Haldol comes in. Okay. This is where they're actually going to be, you're going to see a lot of agitation. They might start getting a little bit confused. So you'll give them medications. You can give these every 15 minutes for 4 doses if you need to. Just remember, you'll also have to conduct that seawall every 15 minutes to determine if they need it. So you'll also assess if the treatment working. If it's not, then this is where you need to call your physician. This is very important. If they're at moderate severity, the medications are not working, you need to call the doctor. Maybe they need to try something else. They might want to already, start to move them somewhere. They might say to give higher dosages of something. So call a physician. You'll continue to follow this protocol. So if they're taking a while to call back, you're going to give this diazepam 10 milligrams or the lorazepam 2 milligrams. You also have higher doses of Haldol there if you need it. You can also see up at the top where it sees your seawall scores. When you're determining which score you fit, the 5 to 14 is the mild, the 15 to 19 is your moderate, and the seawall score greater than 20. Or if you see these vital signs here, that automatically makes them go into severe symptoms. So you have to really watch that stuff, okay? This is where it can get a little complicated, and so it's very important to look at that protocol and have kind of an understanding of it. So then, after you give these medications, the physician might be like, okay, let's already go to the CCU before you even get to this point. Or they'll be like, let's try all this. If the treatment is working, great. We'll continue to use it. But if not, you need to call the physician again. You need to already call, nursing supervisor, let them know that they're going into severe alcohol withdrawal, they're becoming patient safety issue. You need to just call that doctor and get an order, or see, just don't put it off before they start having respiratory problems or anything like that. So that we've kind of talked about this stuff. Remember, I told you to kind of think about those questions as we were going. So, how comfortable are you when taking care of a patient who is actively withdrawing from alcohol? Did this presentation help you feel a little more comfortable? You got to see the protocol. Sometimes it's one of those things, and I understand that, where you have to use it before you're really going to completely understand it. And it can seem kind of complicated, which is why we also have the algorithm there. But hopefully your comfort levels have increased. So then, what is the preferred drug at Olathe Medical Center for treating alcohol withdrawal? Correct. Diazepam, that's great. But what are we using right now since we have a shortage? Ativan, perfect. So what do you monitor on telemetry when a patient is receiving Haldol? Yes, this is the QTC. This is where I said it's very important that if you're on Haldol, that they are getting monitored, their heart rate's getting monitored. And then, according to the alcohol withdrawal protocol, when do you contact the physician if the medications on them are not working? So you contact them after you have tried the moderate treatment, it's not working, before you go to severe. So you're going to contact them if it's not working, and then if the severe treatment is still not working, you're going to contact them again. And use your nursing judgment. If you need to contact them more, obviously do so. You don't have to wait until the protocol says you need to. If you feel like the patient's going to be having problems and it's going to becoming even worse, please, please, please do not hesitate. So thank you guys all for coming, for listening to me talk. Do you have any questions? Now's when we'll kind of discuss. We can go through the CWA again. We can look at this algorithm. If you have any questions, please talk to me. Or any other questions, at all, if there's something you're not understanding, now's the time that we can discuss those.